We are like skin nerds on the verge of weirdos. But that's why we love what we do.
Real skin, real science, real confidence. With Dr. Zain Husain. Welcome to
Skin Side
Out.
Welcome to Skin Side Out. I'm your host, Dr. Zain, with Heather and Courtney. So today we're going to be talking about the top 10 benign things we see on a skin exam from the inside out. So let's get right into it. So we're going to be showing some images on the screen, but we'll also be describing it for our listeners at home. So Heather, I'd like you to take the first one.
So the first one is seborrheic keratoses, or the singular is seborrheic keratosis. These are, like we can see in the photo, really stuck on typically brown lesions. Sometimes they can be flat, sometimes they can be like skin colored, but this is kind of like a classic look to them. They have a very like waxy, warty kind of look. Some people call them barnacles.
What do you like to call them?
Wisdom spots, or
No.
Weeds in the garden of life.
That's so poetic.
They do come with time. They are genetic, so and they're also, you can get them anywhere, but they are very common in areas of friction. So like for females, very common, like where necklaces lie, bra straps, under the breasts, but you could have it anywhere.
I think a lot of people also mistake these for melanoma because sometimes they can look really dark and scary and brown and just
And they can have like black
pieces
dots
coming out. Black dots. So I think a lot of times you'll see someone that's like, I have a melanoma. And then you look and you're like, oh, that's just a SK.
Yeah.
And sometimes they can be symptomatic. So they can get itchy. They can sometimes, have some pain associated, especially if it's like, being scratched off. So that's something that we tell our patients, like if we have a lesion that has symptoms such as, itching, bleeding, it's concerning, but oftentimes they're seborrheic keratoses.
Yeah, they can be treated with liquid nitrogen. There are also some lasers that can treat them as well. Typically, it's considered cosmetic. There's nothing that you can do to prevent them. But those are typical ways that we can treat it. We also used to use, I don't know if you used it a lot, but like, I'm blanking on the brand name, but like a high percentage of hydrogen peroxide.
Mm-hmm.
It seems to work, but
But it was very expensive.
Yeah, it's very expensive.
Yeah. Escada, right?
Yeah.
So I think that these are completely harmless. They don't need to be treated unless they're irritated or they bother you cosmetically. And you can be covered with hundreds of these. So, patients get really alarmed, like, oh, how can you tell what's, a mole versus an SK? It takes a lot of training and being able to decipher what these lesions are. And dermatoscopically, we are able to see certain clinical findings, those keratin horn cysts, we can visualize, and that tends to help us with distinguishing that between other skin lesions. All right, so SK's done. So we have this beautiful red papule. What do we have here, Courtney?
This is a cherry angioma. Basically, these are just a benign collection of blood vessels under the skin. So sometimes people will notice that if they pick at them, it will bleed a lot because it's all those little blood vessels in there. I've heard them called blood moles before, which I think is like, number one, a cool band name. And number two, it's just like a funny, I guess technically, they're not a mole, but it is funny to think about like a little blood mole.
And it's funny how many patients freak out about this too.
Yeah.
I'm like, oh my God, I'm getting so many of these. And, they're like worried it's like a sign of something serious like cancer. But these are also genetically derived. And many times there's a family history of having them. You will get more as you age, just like with seborrheic keratoses. So nothing to worry about. However, if they do bother you, there are treatment options, right? So we can use lasers that are vascular specific. We can use electrocautery. Some people even use liquid nitrogen on these, and sometimes that can help or shave and cauterize.
Yeah, it's fun to laser them. I mean, they'll turn this nice purple, dusky color usually immediately. And it's
very satisfying.
It's so satisfying. My mom, I've told them this, but my mom has like 100 of these things. And
didn't we do some test
yeah,
fires
she
on
has like that big one on her thigh and that cleared up, which I love seeing. But she's just so prone to them. And I've started seeing some appearing on me. So
Yeah.
always in the laser room.
And your SKs, right?
I don't have an SK yet. Okay, I'm not
I think
there.
I have an SK.
Yeah. I feel like an SK is like
tiny.
it's like your sign of aging. Like when you get that first SK, like, oh.
And by the way, I was just kidding. No judgments.
He's judging, obviously.
Another reason why we get cherry angiomas is when our skin cells turn over faster. Sometimes they just like make a mistake and pop that little blood mole up there. So like Courtney said, it's not really a mole, but it's just kind of like a mistake.
Yeah.
And these are like superficial capillaries. That's why it's so intensely red. The blood's flowing through them. There are variations of them. So they can be more veins and like venous blood going through it. So it's more of a purple, violaceous color. So sometimes it can be really dark. Sometimes it almost looks even black. And then when you look under a dermoscopy, you can kind of see that purplish tinge and this beautiful like cluster. It's almost like a raspberry. That's how I describe it. Kind of a texture, and that gives it away that, you know, this is a vascular lesion. There's other variations like pyogenic granulomas, also highly vascular. And these can ulcerate and bleed. So oftentimes we see patients come into the office, hey, I got this bleeding blood blister. And oftentimes, you know, it's a pyogenic granuloma. We treat it. And oftentimes, you know, cures it. There's also another variation called, you know, those angiokeratomas. These are also more like vein-like lesions. They're more purple. And interestingly enough, it can be found on scrotums on men. And that's the most common area we see them. And I've treated many patients. You know, some guys are self-conscious about it. They're completely harmless, but sometimes they can bleed. Spontaneously or with, you know, manscaping. So some of the, you know, patients come in and they want to treat it, and I use a vascular laser. I had this guy a few months ago, maybe 200 plus angiokeratomas on his scrotum, and he did awesome. He did really, really well. With 2 sessions, we were able to clear the vast majority of the angiokeratomas. He felt a lot better about himself. And that's really satisfying.
Did you use cautery or laser?
Laser.
Okay, nice.
Yeah, so I used the Nd:YAG laser, and we targeted the, you know, the venous blood, and it worked really well. What happens when we see an angioma bleed? Is that a cause for concern?
No.
Yeah. Typically, these are pretty superficial. They can be, you know, controlled with just pressure most of the time. But if you kind of get a recurrent angioma that bleeds, it's probably a good idea just to get it cauterized. All right. Next up, we've got this fleshy, skin-colored papule. What is this, Heather?
Probably a skin tag. Maybe an intradermal nevus.
Yeah.
No, skin tags are very common. Most people know what a skin tag is. They're actually kind of related to seborrheic keratoses. So most of them are pedunculated, meaning like they have a little stalk on the...
I love that word, by the way.
Me too.
I love that word. Pedunculated.
Yeah.
Like, it's a good word.
Yeah, it's just like a little stalk at the little stem. Sometimes they're small, sometimes they're really big. Nothing to worry about. They're also common in areas of friction. Genetics can play a role.
I even see the hormonal changes too, pre-diabetics and diabetics.
Yep.
Perimenopausal, menopausal women can sometimes get this. Obese patients. You know, there's some relation with metabolic syndrome, so there's some dysfunction with hormones. Are they dangerous?
No.
Are they annoying?
Yes.
Yeah, they can be annoying, and patients often come to us, you know, for treatment. So this is a cosmetic service. We typically use electric cautery for destruction. You can use liquid nitrogen. You can snip and clip. I mean, old school, but it works.
I shouldn't say this. I told my ex-boyfriend's mom to do this. I was like, just put dental floss on it. I did not want to deal with that.
No, you did not.
I
I
had a patient come in one time, and she was like, I really want this skin tag removed on my chest. I tried to remove it with dental floss. I just like tied the dental floss really tight.
Cut the blood flow off.
Yeah, but then she was like, but it didn't work, and the dental floss is still on there.
Yeah,
so
I've
it's
seen
wrapped around.
I've seen that a lot where, the dental floss, like, is number one, they can't even cut it off because it's so tight at that point,
Yeah.
and then it's stuck on there, and they're like, can you get both things off?
Yeah.
Yeah. And, along those lines, should you be treating these at home? The answer is no. I've
100% no. I just did not care for that woman.
I had a patient who took a knife and tried to like cut it off, started bleeding, then he got infected.
Oh my gosh.
And, that led to an ER visit, antibiotics. I mean, the whole cellulitis picture. You don't want to do that. I mean, yes, it'll cost a little bit of money, but you'll get it done right. You can get multiple done at the same time.
It'll be numb.
You'll numb. I mean, sanitation.
Yeah.
I think I have had a couple patients say that they've tried like nail clippers.
Oh
Ooh.
God,
Yeah.
I've actually heard that too.
Yeah.
And when I used to be a medical assistant, like take people back, they would tell me, they'd be like, I tried to remove it with nail clippers. I would hope to God that you sanitize those clippers before. You just like, who knows?
Yeah, don't be a hero. Just come into the office. We'll take care of it. It's really easy. So there are variations of skin tags as well. So what about those lesions that we see on people's faces? Sometimes they can be flat. Sometimes they're a little bit fleshy. Often hyperpigmented. What are those called?
DPNs.
Yep.
Dermatosis papulosa nigra, which is more common in skin of color. But like Dr. Husain mentioned, it's mostly like a pigmented skin tag.
Yeah. And, most of them are pretty small and not noticeable, but sometimes they can grow. So let's talk about that
gosh.
story of my
You
patient.
love that story. I feel
do.
Like we talked about it.
Oh my God. I should post a picture of that skin tag.
Yeah.
So I had a patient who had this skin tag that started growing from his butt, like right by the, gluteal cleft, the crack. And it kept growing. It grew like a tail.
Literally,
And
there was
it
like
literally
a cord.
was. It was like a cord, and like it had its own pulse, and had this like fleshy bottom, and it would
It's
like
about
dangle.
10 centimeters, right?
It would be dangling
It was
from
a
his
fistful,
butt
yeah.
down to his knees.
Yeah. Well, that's
No, it wasn't
not
that far.
his knees.
Oh, guys. Humor me.
Mid-thigh.
But anyway, it looked like a tail coming out of his butt.
It did.
And he also tried to chop it off and started bleeding, having a lot of pain, had to go to the ER. And we actually excised it in the office. And let me tell you, that thing was hard to excise. It was thick,
that blood
vascular.
flow.
It had blood vessels, like pretty
Yeah, it
significant.
It had
ones.
its own ecosystem.
It really was. It was special.
Well, the weird thing was when he came into the office, he was just like, I have a skin tag I want removed.
Yeah.
Like so nonchalant. We're like, okay, do you mind if we take a look? And then it was like, oh, like that's a pretty large skin tag. Like
Yeah.
literally, it was like,
Large is an
Yeah.
understatement.
yeah.
Yeah, thing was a monster.
Yeah, it's like when you like watch Dr. Pimple Popper and you see
Yeah.
someone go in with like an abscess that's like the size of like their head, and you're like, man, how'd you let it like go that long? And that was like the same sentiment.
And we're talking about this very lightly, but I think like don't feel ashamed if you have something like this. Like we see it all the time. It is kind of satisfying a little bit to see these like these things that we don't commonly see. Like we don't commonly see skin tags that big.
This excites us, like not in a negative way, like in a fun, like it's exciting.
We want to help you.
Yeah.
We are like skin nerds on the verge of weirdos. But that's why we love what we do. But he was very happy after his result. His butt looked so much better.
I would imagine he felt better.
Yeah.
And you know what? Like it was interfering with his daily life,
Yeah,
right?
sure.
Like
Not
that
really
thing,
sitting.
like sitting. And I think he worked in construction or something physical. So like I think that's really what prompted him to actually get treatment.
This is like a crazy question to ask. This is crazy.
Yeah.
But do you think if he was like sitting on the toilet, do you think it touched the water?
Probably.
Yeah. Oh, I never even thought about
without
that.
a doubt. Without a doubt.
Only you would think of
I
that.
would, because like I just feel like that in a sense would like dry,
Yeah.
I would need it off, like yeah.
Because the stalk was probably like this big, right?
It reminded me
Like
of a
lengthwise.
lion's
Lengthwise, yeah.
tail. That's the
Yeah, it
best
really
way I can
was.
describe it. There was a tail,
And it was
and
probably this thick. The actual stalk was probably.
oh, it was yeah.
Yeah.
For me, I can't imagine, like, I felt a skin tag on the back of my thigh one day that was probably the size of, like, I don't know, maybe like a dime. And immediately I was like, this needs to come off.
Well, I
Like,
think he waited so long.
He
I think
waited
he
a long
did
time.
admit that he was like embarrassed by it, and he
Aw.
thought like like he didn't know what to do and he thought maybe it would go away or something, but it just kept getting bigger.
Well, kudos to his girlfriend. She never made him self-conscious about it. She was very supportive. So I thought that was cool.
Yeah, that's so true.
Yeah.
All right.
You better marry her.
All right. So we have 6 images here of these hyperpigmented macules and papules. So, flat lesions and some of them that are raised. What are these, Courtney?
These are benign moles. You might also hear the term nevi. That is just the medical jargon for moles. So moles can appear in like all different shapes and sizes. I think people tend to get anxious about new moles. I think context is everything when it comes to a mole. I think taking into account like what your normal subset looks like, taking into account, how new it is or if it's been there for a while, if it's changing. But a lot of times people will come in with concerns about a certain mole and, if they are normal, we're able to usually tell them. So we see a large variety, I would say, of moles, both, flat and a little bit raised.
Mm-hmm. And we're kind of looking for, like Courtney mentioned, like everybody kind of has their signature mole. So we're kind of looking for what we call the ugly duckling sign, where we're seeing, okay, based on how all of your moles present, which one is like really standing out to us. Like for instance, like in these photos, like if a lot of your moles look like the bottom center one, but then you have this one up top that's like maybe a little bit asymmetrical, then that might stand out to us. It could be benign, but it's definitely the one that doesn't seem like your typical.
And I know that we discussed it in a prior episode on skin checks, the ABCDEs of melanoma. Can we go through that again for our audience?
Yeah. So so these are red flags. It's not like a hard and fast rule, but A stands for asymmetry. So if you were to cut the mole in half, is the left the same as the right or top versus bottom? If it's not, could be a red flag. B is border. So if it kind of has wonky borders, so like I mentioned, like that top center one, the borders are a little bit different. They're not quite spherical. But that could be potentially a sign to biopsy. C is color. So technically you can have 2 different colors in a mole and it can be benign, but it's not a guarantee. But anything more than 2, especially if it's like grayish white or like has some sort of like black hue to it, that could be a red flag. D is diameter. So if something's bigger than 6 millimeters, so like the size of a pencil eraser, that can also be concerning. But however, there are moles that are bigger and are fine. Yeah. And then E is evolution, so something that's new or changing.
And like you can see just with these 6 images, there is clinical variety. And there's so many different variations that, we see on patients. So we rely often on dermoscopy, which allows us to magnify, look at the moles with more precision, look at pigment patterns and other clinical features to help us diagnose and also decide whether we need to biopsy or not. And I think that's been really helpful and has changed the landscape of dermatology, where we just used to rely just on our naked eye. Now we have other tools that we can use to, help us make those clinical decisions. And in addition to this, like another thing that I commonly hear from my patients is that, I'm worried because this mole is raised. And that doesn't necessarily mean that it's harmful. So there are intradermal nevi, which are moles that have a little bit of elevation because these collections of pigment-producing cells called melanocytes are just distributed in such a way that it actually has a raised component. Another one that we see, congenital nevi. So these are moles that patients have had since birth or shortly after. And they often have also signature benign features, but they can look a little scary sometimes. Sometimes they have hairs growing through them. That's nothing that we need to be worried about. And sometimes they're raised, have different colors in them. But what really gives us some more reassurance is that it's been there for a while, hasn't changed, and we often can reassure our patients.
And you can develop new moles up until, 40 usually? And not that you should just put aside any like new mole that you get, but that being said, I think we do tend to see a lot of like kind of the younger generation who's more in tune with their skin, I think, just based off of, like social media and being more cautious, which is great. But yeah, sometimes you'll get that patient that's like coming in with like every single new mole. And you're like, nope, looks good. But like, let's just continue to monitor. Like if it's changing, like let's take a peek. But sometimes I will see like those patients who are in their like early 20s and maybe even like early 30s that are like, oh, this is new. It's that teeny tiny little pigment. And you're like, let's just monitor.
And moles can change, right? So with sun exposure, UV radiation, moles can sometimes change in pigment. Doesn't necessarily mean that they're harmful.
Pregnancy, I see.
Pregnancy, estrogen, and other hormones can influence the appearance of moles. So, we always take the patient's history and the context when we're making decisions about whether to biopsy or if we're concerned about things.
And I would lastly add to that, if your gut is just telling you, I do not like this mole, you should your provider should take care, they should biopsy it.
Or if it's giving like a weird sensation.
Yeah.
Or
Sometimes
if
you
it's
just
itchy.
know. Yeah. I had a dysplastic mole on my arm that I had told my provider that I wanted biopsied. She's like, it's fine. It's benign, and ends up coming back severely atypical. And like, I just, just trust your body.
Yeah.
And that's also important to listen to your patients. I mean, unless it's like a clear cut, like, oh, it's an SK, we can really reassure them. I mean, if there are symptoms associated with it, I have a low threshold to biopsy. I mean, biopsy is a low risk procedure.
Takes 2 seconds.
And you get reassurance, and peace of mind is valuable, in my opinion. So instead
Agreed.
of worrying about it, like constantly monitoring it, I'm happy to take it off, and then you can get an answer.
Yeah.
Okay. All right. So we have these dark, flat macules in kind of irregular shape. What are these?
Liver spots. I just wanted to say that.
Is this a back?
No, it's
or-
a hand.
It's a hand.
Oh, okay. I thought, was this his like trap? And
No, I
this
think
is
that's his hand.
face?
Yeah, that's
Okay.
his thumb up there.
Okay, I see.
Wait, should I visually describe what for
Yes.
people who are not watching?
Lentigines.
Lentigines. We're looking at the back of a hand. It's a little wrinkly, probably an older person, maybe in their 60s or 70s, and there's multiple brown spots that are variable in shade and color.
And now this is where it gets kind of tricky because like this one in the middle, like it is pretty asymmetrical and people might think, oh, that's a mole. I need to be concerned. What if it's melanoma? Lentigines, or the singular is lentigo, they can very commonly be asymmetrical in the borders. We call it like a moth-eaten appearance. It kind of looks like a moth took a bite out of it. And that is very common. It's not concerning. However, there is a type of malignant form called lentigo maligna, which is obviously concerning, but don't just assume that because it's asymmetrical that it's worrisome.
And these lesions are typically more superficial. So on dermoscopy, we can see patterns that look very reassuring. And it's just an indication of a lot of sun exposure, sun damage. We see it on sun-exposed areas especially. So the back of the hands, the face, the neck.
Shoulders.
And, a lot of people, don't really like the way that it looks. So we do have pigment-specific lasers that we can use to help make it look better. But it's so important to be evaluated by your dermatologist or team because we want to make sure that, they're completely normal. They're just lentigines, background sun damage. They aren't anything concerning like a pigmented lesion that's concerning for like an atypical mole or melanoma, because that is a big no-no.
That's what scares me, I would say, most about like places that do cosmetic procedures that don't have dermatology, like a dermatologist on practice, I would say, because I think it's so scary. Like, I think any other person could be like, oh yeah, we'll just hit that with like the laser and just treat the pigment. But without having like someone who truly knows what to look for, again, like that melanoma is always just sitting in the back of my head. And like, I'm never one to hesitate to pull either of you guys when I see a spot that's like a freckle that's just like, I don't like how that looks, And I think that's what scares me most about like the med spas that just treat.
Well, yeah. I had a patient, she wasn't my patient, but at my previous practice where she came in and she had a spot on her face lasered multiple times and it was melanoma. And she was young. She was maybe 40 and she had a huge scar.
Oh my God. That scares me.
Yeah.
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 And how is this differentiated from freckles or ephelids?
Freckles are usually like tiny, circular, very even, I guess, in the shape. Typically, there's a little more genetic component to that. You can get more with sun, but these are more like, I guess, more common to get over time. So it's more common, like,
Accumulated.
with the older age,
Yeah.
I guess.
Like kids, can often get freckles,
Yeah.
and especially with lighter skin types. So we do see that a lot.
I feel like mine wax and wane. Like they get more prominent in the summer and then kind of.
For your freckles.
Yeah.
Yeah. And you mentioned liver spots, and like that is called liver spots.
It's a very southern
actually,
thing.
Yeah, there's actually no correlation to the
Yeah.
liver. It's not concerning at all. I think the reason why they called them liver spots is because they have the same color as a liver.
Okay.
But it
So I
doesn't
call them
mean
my chocolate chip spots.
right. But it doesn't mean that you have like a liver abnormality or anything.
Yeah.
That's a good point to bring up because I do think people associate.
Yeah.
All right. So those are our lentigines. Let's move on. Okay. So Heather, you want to give a description?
Sure. This looks like a pink papule with maybe a central either induration or discoloration.
What's induration?
Like a little indentation. So this looks like a dermatofibroma, and the reason why I bring up the central part of it is because there's a classic sign for these called the dimple sign. And if you kind of like squeeze at it from the sides, the center of it depresses, and that kind of reassures you that it is a dermatofibroma, which dermatofibromas are little scar-like bumps. It is very common. It is most common on female legs. It could be due to shaving, ingrown hairs, bug bites, any sort of trauma. It's just like a little scar. But I wouldn't just assume that it's benign because it creates a little dimple in the middle. Like I said, that's the classic sign for it, but not all dermatofibromas have the dimple sign, and then vice versa. Just because it has a dimple sign doesn't mean it's fine.
And like Heather mentioned, it's often related to some type of trauma. So, like shaving or an ingrown hair or like a bug bite. However, it can also happen in the setting of certain systemic diseases. So, for instance, I've seen this in HIV patients. I've seen this in connective tissue disease patients like lupus. So, when you do see a bunch of these, that does kind of raise some flags. I mean, is something else going on, or just all this repetitive trauma? And you can also get this in the setting of acne. So, like some people get keloids with certain acne lesions. You can also form dermatofibromas as well. So that's another reason why I tell my patients not to pick at or manipulate their acne, because you have the potential for keloiding or forming dermatofibromas, which are difficult to get rid of.
Yeah, sometimes I know occasionally you can offer like a steroid injection to the area to try to flatten it out a little bit. Occasionally, if it's really bothersome and painful and itchy, surgery can be done, but you do kind of risk removing that, essentially a scar with, another scar.
Sometimes we use cryotherapy too. Sometimes that can flatten it out, but it's a hit or a miss. Dermatofibromas are really annoying and tough to treat.
And there's a worrisome type called DFSP, which is typically if your dermatofibroma is changing, then I would definitely have it rechecked.
Yeah, so that's malignant. That is cancer. We surgically treat those typically with Mohs surgery or wide local excision. And that's something that is oftentimes missed because they kind of look like scars and, patients kind of do not correlate them with something that's growing. It's odd. Like actually I had one of my cousins who had something on her abdomen and she had a biopsy. It came back as DFSP.
Oh, wow.
She's like, oh, what should I do with this? I'm like, oh, you need to see, a Mohs surgeon, get rid of it. This is cancer. So it is an unusual, but we do see it.
Yeah, I've only seen it one time in a patient. He was in his early 30s and it was on his chest. And sure enough, we, removed the whole thing. But it was just interesting to see the presentation and kind of how it differentiated from, just a regular dermatofibroma. So,
All right. I love these pearly white papules underneath this eyelid. Courtney, what are these? Your favorite?
Milia, the pimple you can't pop. Milia are basically tiny white bumps. You can think of them if you've ever, in fact, you guys will laugh at me. I literally just popped one last night. I had my little 11 blade at home and I went in there. I knew it was a Milia because it wasn't coming out with my Q-tip. So I just created my little opening and popped it out. Basically, these are very common on the face and sometimes on the neck. We'll see them. It's basically, I describe them as almost like little cysts to my patients. I feel like that makes like the most sense. They're kind of clogged pores that they don't really have an opening. So really by you pushing and shoving, it's not going to do anything other than just create inflammation and potentially scarring. So you do really want to see someone who can actually create that little opening and then help express that material out. So they are benign. I tend to see them one of kind of three ways. I think genetics does play a little bit of a part. I think friction also. Sometimes if people rub their eyes a lot, I tend to see them around the eyes. Or the other thing would be like an overuse of like a moisturizer. So especially again, that eye area, I think if someone's using really overly moisturizing ingredients, then we'll start to see those pores clog and get that milia around.
Especially with occlusion, Aquaphor, Vaseline.
Would you like Aquaphor on the
I do.
Yeah.
I love the moisturization, especially for sensitive skin.
Yeah.
But like, if you don't need the moisture, then you don't use it.
Yeah, take it with a grain of salt.
And there's typically keratin in it, which is a skin protein. But yeah, they're completely benign.
Yeah.
Yeah, they are fun to extract. They're usually
They
just a
are.
little white pearl that that you'll get out. But
But like with the skin tags, I would not advise doing that at home.
No.
Go to a professional because with any manipulation, you can have inflammation, scarring, and it's often on cosmetically sensitive areas like your face. So
around the eye especially. Yeah.
And you don't want to bring sharp objects by your eye.
Unless you're
Yeah.
me. No, I will say it was last night that I did it, and yeah, I had my little 11 blade. But it's hard to see. It's right here, and it's hard to like in the mirror see that. So I did almost think about just waiting until today to have you do it. But I was like, no, I can do it. And the first poke, I definitely didn't get in there, and I was like, that's okay. We'll just do another. And then when it came out, I was like, oh. Glory.
Yeah. And there's some lesions that can look very similar to Milia. So syringomas, these are these benign sweat duct growths that can also be found under the eyes. Sebaceous gland hyperplasia can sometimes look like this. Even little acne cysts can look similar. So they're all benign, which is a good thing, but sometimes they require different treatment options. All right. So we have these waxy, umbilicated, or has like a little tiny depression in the center, orange to skin-colored papules on the face. What are these, Courtney?
Sebaceous hyperplasia. So these are basically enlarged oil glands, and I think a lot of times they get confused with milia. A lot of times when I'm doing facials, people will think that they are milia. But it's funny, even if you were to take a little blade and pop that open, sometimes you'll actually express oil out of there. So they do tend to kind of, even with my own, I tend to see them flare a little bit, where sometimes they'll get a little bit more raised and kind of like die back down and kind of go through that cycle. They are completely benign, but there are multiple ways that you can take care of them. The number one specifically being cauterization, where we do kind of singe those areas. But I think the main difference between these and milia, number one, a little bit is the coloration. These will tend to appear a little bit more orange than white. And then the second thing is definitely that indentation is kind of my telltale sign that is definitely a sebaceous hyperplasia and not a milia.
But you do have to be careful because there is a type of skin cancer that often gets confused called basal cell carcinoma, and that can sometimes have an induration in the middle. And they both typically look very like shiny and pearly. So you definitely don't want to assume that that's an.
And there's a malignant version of these growths called sebaceous carcinoma, and that is also a serious a condition that we treat with Mohs surgery. With the sebaceous gland hyperplasia, what are some of our treatment options for patients aside from destructive methods? We often prescribe some medicines. What do we typically prescribe?
Retinols can help. I think if you have a lot of them, it's very difficult to treat all of them with just a retinol or retinoid. They can definitely help prevent. Also, salicylic acid can help target excess oil to prevent some from forming. These are very common in acne-prone individuals. So if you do have a history of acne, or if you have,
Rosacea.
or more oily skin type in general, you might get the sebaceous hyperplasia, but it's kind of, you do have a perk where you're probably not going to form as many fine lines and wrinkles because your skin is oily. A couple of different options.
I like using Accutane for patients who have severe sebaceous gland hyperplasia. It just melts them away. It also reduces the oil production, which is also another problem these patients complain about. So one of the other beautiful things about Accutane that we can use for.
We actually used to use a laser at my last practice, but we would mark it, because there's not a lot of pigment on there, we would actually mark it with like a red marker. And then I think we were using maybe a 532 on there, and basically kind of creating a little bit of like that destruction. And then we would actually use some Q-tips to express the oil out and hit it again. And that actually worked pretty well.
Yeah, I mean, I think there were a few lasers that were used to target acne with a specific wavelength. I think the 1726 nanometer, like the AviClear, and the Accure laser. But I don't really know if it really helped that much.
I think for the cost, honestly, cautery is such a better.
Oh,
Pretty
yeah.
painful too.
Should we say this next one all together?
Let's do it.
Idiopathic guttate hypomelanosis.
I love that word. Or
And I love it when patients look at us after we say it, like, what?
Yeah.
it's like you're speaking an alien language.
Sometimes I'll ask them to repeat it, and they're just like,
And you sound really smart.
So smart.
So what are these lesions?
They're kind of like white freckles. So they're sun-related little hypopigmented macules, meaning like flat spots. They are more commonly seen in the summer, and that's really, obviously they're sun-related, but also they are just more apparent because if you get tan in the summer, then the contrast between those spots and your normal skin are higher.
And some categorize it as a subtype of seborrheic keratosis that are just hypopigmented. So rather than being hyperpigmented like many of the ones that we saw in the past, on another slide, these are just, less apparent because they have no pigment, or less pigment.
There's not much that you can do to treat them. There has been some success with liquid nitrogen, which I think a lot of people don't think to freeze them with liquid nitrogen because there is a risk for hypopigmentation from the liquid nitrogen, but there is a little bit of inflammation there associated with the spot. And so if we can lightly freeze it, it could calm down the inflammation enough to where the spot would go away, but it's not a guarantee that it would be successful.
Have you seen improvement with chemical peels? Have you ever tried them on them?
I haven't. I'd actually be more intrigued to try something like Latisse and do like a little microneedling on them.
Do you think chemical peels would be more effective because it's lightening the normal skin? Or
No,
do you
I think it's more like these superficial growths.
And it's just exfoliating them off.
Exfoliating them off. Because I don't really think of them as vitiligo-like lesions.
Yeah.
So like the Latisse, mechanism is more for like depigmentation. I don't consider these the same category.
Yeah. You run the trial and let me know how it goes.
We'll do it.
It's probably a lot harder to do Latisse in just because they're
So many.
typically so many.
Take a Q-tip and
All right,
Yeah.
you
Okay,
try that.
you can do that for an hour.
And now we have our final image. So Heather, I know that there's a lot of redness over there. That's not what we're looking at. We're looking at that little bump by the nasal ala. What is that?
That is a fibrous papule. So these are little benign growths that you can get very commonly on the nose. It has a little bit of fibrotic tissue there. A lot of times it can look like a raised mole, like a flesh-colored mole, but they are a little bit different. They're typically a lot firmer than a mole.
And a lot of people don't like the way that they look. So I often do cosmetic shaves, or if they're really small, a little bit of electrocautery destruction, and they heal up beautifully. So patients are typically very happy with that.
They tend to like, I've heard patients call them like clear moles before because I feel like they're not, like you said, they're not as pigmented usually. And they also, sometimes you can actually see like the vascularity in them, and they just tend to have like that more like clear appearance.
They're technically a form of angiofibroma. So that's why you kind of see the angio, which is the blood vessels, and the fibroma, the fibrous tissue. And very normal, often genetically influenced too. There are also genetic syndromes that can be associated with angiofibromas, like tuberous sclerosis, for instance. So you can see a ton of them on the face. But yeah, these are pretty common, and most patients are just annoyed cosmetically, or they're worried about, oh, this is skin cancer. Okay. All right, so there we have it. Those were the 10 most common benign findings we see on skin exam. So not everything that you see on exam is something to worry about. However, it's a good idea to get checked regularly by your dermatology provider. And if you are worried about something, if it's changing, if there's symptoms associated with it, you should definitely get it checked out. It's worth knowing, and we can determine if a biopsy is necessary. I think peace of mind is always a great thing. Any last words?
I was just going to agree. Even if you feel like, you see one of these things and you're like, oh, I think I have this freckle or whatever. These are benign lesions, but things can always be out of the norm. So it's always better, to get something checked that is changing, that is having, a little bit of like variety that doesn't look like the norm. It's always better just to get that checked than just to assume that it's benign.
And many of these lesions have a more sinister malignant counterpart sometimes. So there can also be a time of transition between a benign to a malignant lesion. So something to keep in mind. Well, I hope you enjoyed this episode. I think it was a nice addition to our anatomy of a skin exam episode. So hopefully you get a clear idea of what a skin check is, what we can find on it, and just have a little bit more reassurance that most things that we find are benign. Hopefully you enjoyed this episode, but until next time, Skinside out.
Thanks for listening. This episode of Skin Side Out is complete. If you enjoyed today's episode, don't forget to subscribe, rate, and leave a review wherever you listen to your podcasts. For more tips, updates, and behind-the-scenes content, be sure to see what fun we're up to on TikTok. Follow us on Instagram and Facebook at Nor Dermatology and Aesthetics. Check us out online at norderm.com. Discover why our patients give us 5 stars on Google. Call us today at 919-617-0717.